Well, shall we begin, Nathoo?
Yeah, I think so. So yeah, I've started the session recording and one more people in. I have people waiting. Okay, so hello and welcome everyone to another session of Summer MS Lecture Series. Today our speaker is Dr. Nabeela Nathoo. Nabeela was born and brought up in Calgary, where she completed her bachelor's, MD, PhD in neuroscience, all from the University of Calgary. Her PhD thesis was supervised by Dr. Jeff Dunn and Dr. Wee Young, where she looked at pathology in EAE model of MS using susceptibility weighted imaging. She's currently completing her third year of neurology residency at University of Alberta. She has plans to pursue a career as a clinical researcher with specialization in MS and autoimmune neurology. So we are looking forward to the talk.
Awesome. Thank you very much for having me. So I know that's going to be kind of a wide-ranging audience. So please jump in and ask questions. And for the people who do MRI research, the beginning might be a little bit of a review, but I recognize that there's going to be kind of a wide range of people, so I want to make sure everybody feels comfortable at least with the basics. So for this morning's talk, I'm going to start off with a bit on the basics of MRI, and like I said, for the MRI people, this will be probably too basic, but that's okay. I'm going to talk about the clinical utility of MRI in MS at present, the way that we use MR, and then kind of moving forward, what the uses have been of MRI in MS in the research setting. And I'll talk mostly about research in MS patients, but also about the sort of unique things that we can do in animal models of MS using imaging. And these are kind of the specific areas that I'll address today. So for the basics of MR, instead of me describing this to you, I have a short video that is basic. So hopefully those of you who do, immunology and things like that, at least have an introduction and understand how it works. So I'll play that out first.
MRI is a medical imaging device commonly used to examine the soft tissues of the human body. Let's meet the machine. The key components are the magnet, radio waves, radiant, and a computer. Our bodies are made up of 60% water, and water is magnetic. Each of the billions of water molecules inside us consists of an oxygen atom bonded to two hydrogen atoms. We know it as H2O. Small parts of the hydrogen atoms act as tiny magnets and are very sensitive to magnetic fields. MRI stands for magnetic resonance imaging, and an MRI scanner is one of the main diagnostic tools that doctors use to examine inside our bodies. The first step in taking an MRI scan is to use a big magnet to produce a unified magnetic field around the patient. The gradient adjusts the magnetic field into smaller sections of different magnetic strengths to isolate specific body parts. For example, the brain. Normally, the water molecules inside us are arranged randomly, but when we lie inside the magnetic field, most of our water molecules move at the same rhythm or frequency as the magnetic field. The ones that don't move along the magnetic field are called low-energy water molecules. To create an image of a body part, for example the brain, the machine focuses on the low-energy water molecules. Radio waves move at the same rhythm or frequency as the magnetic fields in an MRI machine. By sending radio waves that match or resonate with the magnetic field, the low-energy water molecules absorb the energy they need to move alongside the magnetic field. when the machine stops emitting radio waves, the water molecules that had just moved along the magnetic field release the energy they had absorbed and go back to their position. This movement is detected by the MRI machine, and the signal is sent to a powerful computer, which uses imaging software to translate the information into an image of the body. By taking images of the body in each section of the magnetic field, the machine produces a final three-dimensional image of the organ, which doctors can analyze to make a diagnosis.
Okay, so after that oversimplification, I think the gist I want, at least people who don't do imaging and have no plans of doing imaging, is to understand that within your body you have mostly water, and with that you have hydrogen atoms, which are just a single proton, and so we can exploit that, because essentially these are little magnets themselves, with a large magnet to produce contrast in images. So this term T1, or longitudinal or spin lattice relaxation, is basically after you apply that radio frequency pulse, you tip all of the spins, and it's the time that it takes for 63% of that to come back. Now, anything that can exchange energy well, like fat, has a short, what we call a short T1, and that appears bright on T1 weighted MRI. And the purpose of this is for you to see that cerebrospinal fluid has a longer T1, and so it's dark. So that's essentially to define T1 in very basic terms. And then T2, the other term that you hear, is transverse or spin relaxation. So the spins themselves are tipped by the magnet, but then the spins also interact with the spins around each other, and that's what we call T2. So when they're tipped, they're all aligned together, and then as time goes on, they essentially spread out and fan out. And with that, again, if you have efficient interactions, you have a short T2. And again, you can see here, CSF has a longer T2. And so essentially the point is these create different types of contrast. So first things first, T1 is always longer than T2. And they basically laid out what the kind of general values would be for white matter, gray matter, and CSF at different magnetic field strengths. So most often we'll use either 1.5 T, or if we get lucky, 3 T. And for those of you that don't do MRI work, the basic gist is on T1, white matter is bright, gray matter is gray, and CSF is dark. On T2, white matter is dark gray, gray matter is lighter gray, and CSF is bright. And then this other type of imaging that's very commonly used in MS called FLAIR, standing for fluid attenuated inversion recovery. It's similar to T2, except you suppress the CSF, and that lets you see things around the ventricles much better. And so white matter is dark gray, gray matter is light gray, and CSF is dark. So just to give an example of what these images look like, so you can see on a T1 weighted image, your white matter is bright, your CSF is dark. And then on a T2 weighted image, your CSF is bright. You can see that white matter is kind of dark gray, gray matter is lighter gray. And then on FLAIR, your CSF is dark. So as you can tell, you would probably be able to see things around the ventricles better. And the general notion is that T1 weighted imaging is good for looking at like anatomical structures and kind of looking at the size of them, whereas we tend to use T2 weighted imaging and FLAIR for more looking at pathology. And for those of you that want to learn MR more in depth, the way that this book is written is quite beautiful. And then there's also a free website where you can peruse kind of for the more specifics of MR physics for those of you who are going to be doing some MRI. So the clinical utility of MRI in MS at present. So in general, in neurological conditions, we will use MRI to understand the disease CNS, either for the purposes of diagnosis, to monitor disease progression, to learn about disease processes, and then to monitor response to treatment. So within the realm of MS specifically, it does have a pretty significant role for MRI. We use it to support the diagnosis through what's called the McDonald criteria, and I think Dr. Smythe will have probably talked about the clinical aspects of MS, so I'll touch on the McDonald criteria because I think it's important from an MRI standpoint. But the recommendation is that if somebody comes in with what sounds like a clinical demyelinating event, you would obtain a brain MRI with and without gadolinium, and I'll get to that. And if you can, also to get the spine, and if you can only pick one part of the spine because it takes a long time to image the entire spine, it would be the cervical spine. The key thing is that MRI alone cannot be used to diagnose MS. This is first and foremost a clinical diagnosis. MRI is what we would call a paraclinical kind of supportive measure. And I very much appreciated this when I'd read this a while back, but there's no single pathognomonic clinical feature or diagnostic test. Diagnosis of MS relies on the integration of clinical imaging and lab findings. So this is very, very critical, right? So this is one thing to keep in mind. And as has been mentioned already, right, we use MRI in the disease CNS, and so in MS to monitor disease progression, treatment response, and it's a primary outcome measure in phase 2 clinical trials, so very important, and then a secondary outcome measure in phase 3 clinical trials, primarily at this point using like lesion counts and volumes, although there's a push to try to include more advanced MRI with more specific measures for clinical trials. So the McDonald criteria, which I believe will have been raised in a previous talk, but just to discuss where MRI falls into this. So in order for you to get a diagnosis of multiple sclerosis, you need to have had a clinical event that sounds like what would be in keeping with MS, so something like optic neuritis or transverse myelitis. And then you need to meet this criteria of dissemination in space. So what that means is you need to have one or more of these T2 or flare, hyperintense lesions that are found in characteristic areas where we pathologically have seen MS lesions. So these include periventricular, cortical or juxtacortical, so just abutting the gray-white matter boundary, infratentorial, and spinal cord. And then the dissemination in time aspect is the second part, where you would either had two clinical events, or from an imaging standpoint, you would have had one gadolinium enhancing lesion in one location, which tells you that there's ongoing breakdown of the blood-brain barrier, so there's current inflammation that's ongoing. And then any non-enhancing, so T2 or flare hyperintense lesion in a different location. Or if you rescan them down the road to have a new T2 lesion in a separate location compared to the first one, or another gadolinium enhancing lesion. I'm going to pause here. Does anybody have questions? Because this part can get quite confusing when you read the criteria. And then once you start seeing, if you see patients, it gets a lot easier. But any questions at this point? And I realize I can't see a chat box. So if there is one, I don't know about it. Okay, I'm going to keep going. So currently, when we think somebody may have MS, the standard sequences we get are T2, flare, T1 with or without gadolinium, and that's why I kind of went over what these look like before. And again, the gadolinium is to look for signs of active breakdown of the blood-brain barrier, and then for the spinal cord, we do the same thing. Now, it's been proposed kind of within the last little bit here that we should add other types of imaging, and I'll go through, particularly I'll talk about the central vein sign moving forward, but at this point, the first part is all we do. I do think there is value in imaging something like adding an MRI of the orbits if we think somebody might have had optic neuritis. And we had a patient actually 2 days ago who had what's clinically sounded like optic neuritis, known MS patient. And we ended up imaging the orbits as well and saw that there was a new lesion that corresponded to the optic neuritis that she clinically had. And so that did actually affect our management, especially since she also had another lesion. So I do think it can be useful to add some of these measures, but the difficulty is ensuring that there's consistency across centers, particularly for these more advanced types of MR. It's kind of classic MR findings. In the leftmost image, you can see some periventricular hyperintensities, and then in the middle image, coming off the corpus callosum, you can see what are called Dawson's fingers. So they're quite perpendicular, and that's very classic for MS. And then the rightmost image is a T1 weighted image. And if you look, you can see, I don't know if you can see my arrow, but there's kind of in the middle part, there's an area that's just darker. And that's a T1 weighted image, but it's called a black hole. And that's actually identifying that there's been quite a bit of axonal loss in that area. And again, that's quite in keeping with what we would expect in MS. And then here you can see the spinal cord. So it's just a kind of an axial image, and you see a bright area that would be in the dorsal column. That's also very classic for MS, and people in that setting will often present with what's called Lermite's sign. So if they flex their head to their, if they flex their chin to their chest, they'll feel an electrical sensation going down the spine. That's very classic for MS. And then the middle image shows kind of just some patchy hyperintensity in their cervical spine. Again, that keeping with MS. And then the rightmost image, you can see some enhancement of a lesion in the cervical spine at the level of C2, and then some more kind of in the C4 to 5 area. So I just want for the learners to see what kind of classic MR findings look like in MS. And then to kind of move on from there. So MRI is very useful for the diagnosis of MS, but there's this clinical radiological paradox that has been persistent where unfortunately MRI measures don't really correlate well with clinical disability in MS patients. So you can have an MS patient with an EDSS, or this expanded disability status scale of 6, where they need something to help them walk for 100 meters, with fewer lesions than an MS patient who has an EDSS of 3, so much less disabled. And so MRI is helpful in some aspects, but this is kind of the critical thing, is we want MRI methods that correlate with clinical disability. And so the ways to resolve this that have come up are kind of twofold. One is to have more sensitive and specific MRI methods that correlate better with disability and disease progression. And that's what I'm going to talk about kind of for the rest of the talk. And then the developing better measures of clinical disability. EDSS is unfortunately very heavily focused on motor symptoms, and I think that's something that people are trying to work on. The difficulty is you can have a clinical measure that could be reproducible, but it may also be very tedious. And so the EDSS is quite quick and easy to incorporate into doing an exam for a patient, and that's part of the reason that hasn't really changed yet. However, that being said, MRI is very good for looking at subclinical disease activity. And so there's this concept where people are treating quite aggressively. It's called NEDA. So no evidence of disease activity. So even if people aren't coming in with any clinical relapses, there's this notion that we don't want them to have any MRI activity either. And so this concept of NEDA includes no clinical relapses, no disability progression, and then no MRI activity. Like I said, these are thought to be subclinical relapses. And then this NEDA-4 measure includes whole brain volume loss. So there is interest growing around this concept, and it has been incorporated into some trials as a secondary outcome measure. It's not something that we talk about kind of day-to-day in the MS clinic right now, but I think it's definitely being used more heavily in the research setting, and I think a lot more in the United States, to be honest, than Canada at this point. And then I'll just touch on this entity of radiologically isolated syndrome. So I've said that you need to have a clinical event in order for you to get a diagnosis of MS. There are situations, though, where you'll have patients who come in with imaging findings in keeping with MS, but they haven't experienced any clinical events. And so there's very interesting research being done in this area around what high-risk features exist, both as patient characteristics and with the MRI, with respect to who will go on to develop MS. And there is a decent number of people who do go on to develop MS. I actually think that my understanding is that the largest database of RIS patients is actually in Toronto with Dr. G1O. And I think that's become quite an interesting area clinically and imaging-wise. So the high-risk features that have been described in this kind of seminal paper that was published in 2014 are if you're a man versus a woman, if one is less than 37 years of age, and then the presence of any spinal cord lesions, which included cervical and thoracic. And if you were to pick amongst the three kind of characteristics, the one that's highest risk is having any spinal cord involvement. So if somebody comes in and if they have an MRI, brain MRI that looks like RIS, it's very prudent to get a C-spine MR. And then if people had 3 risk factors or more, they were much, much more likely to go on to develop a clinical event and become defined as MS. So I'm going to spend the rest of the time, probably about 20 minutes or 25 minutes, talking about the specific uses of MRI and MS research itself. So kind of the more not being used clinically right now, but being considered to being used clinically down the road, things that are being done in the research setting. So there's some interesting work that's particularly been done in the past where studies have looked at the relationship between MRI lesion load and clinical disability. So this study from 2008 had 107 patients that were followed over 20 years. where 63% went on to develop MS overall. And what they found was that even from the first scan, the T2 lesion volume was moderately correlated with a 20-year EDSS, and that the rate of lesion growth over 20 years, if it was low, they would remain as relapsing remitting MS, while those who had greater lesion growth would go on to develop secondary progressive MS. And I should note that in this 63% who went on to develop MS overall, for people who had a normal baseline MRI, so come in with a clinically demyelinating event, but don't have a normal brain cord MR, the risk of going on to develop MS was more like 20%. So this is the combined value. And so there is, I guess the point to make is there is value and some prognostic value, I guess, in what the MRI looks like when people first present. But again, that correlation kind of in a more, I don't know, shorter timeline is not particularly helpful, but it is helpful when we look at how people do kind of over the span of 20 years. So I thought this is quite an interesting study, and I think it would be very interesting to reproduce that at a time when there are disease-modifying therapies present. Like in 2008, when this was published, there was only the interferons and Copaxone and natalizumab. And so I'm curious to see how this would look with the inclusion of DMTs. So MRI and MS that I'll kind of talk about is, you know, we look at inflammation because it's an inflammatory demyelinating condition with neurodegeneration also present, and then kind of the other uses of MR and MS. So studying inflammation and MS with MR, so this will be more around kind of contrast agents that exist. And so at this point, our way for looking at ongoing inflammation in MS with MRI is by using gadolinium. And again, that's because if there's blood-brain barrier breakdown, gadolinium can seep into the CNS. However, there has also been use of these iron oxide-based nanoparticles. So they can, and I'll go into this in a bit, but they can be essentially given IV, and they're taken up by macrophages in circulation. And then they're imaged using T2 or T2 star weighted MRI sequences. And the purpose of this, so the top one, the gadolinium, is to look at blood-brain barrier breakdown. The second one is to look at infiltration of macrophages into the CNS. And I think the really interesting literature that's come out of this is the fact that there's a mismatch between blood-brain barrier breakdown and macrophage migration into the CNS. So you can have what seems like an intact blood-brain barrier, but you can have infiltration of macrophages into the CNS. Now, at this point in time, from the last time I had looked at this, the licensing, like the FDA approval to use these ultra small particles of iron oxide, or USPI, is basically these nanoparticle contrast agents, is only in the context of liver disease. So it's not licensed to be used in like day-to-day clinical setting in patients. So this has been used in a research setting. And so this study from now a number of years ago shows a standard T2 weighted MRI sequence on the leftmost image. And you can see some hyper intense areas involving some of the white matter just by the basal ganglia. And then with the middle image, you have a T1 weighted image after gadolinium, and the arrows thankfully point out the areas that are bright there. Now, if you compare that with imaging after giving these ultra small particles of iron oxide, you can see that there are obviously more areas that light up than what's seen with gadolinium, and that suggests that you're having infiltration of macrophages into the CNS that are not being seen in areas that also have concurrent blood-brain barrier breakdown. It seems like the blood-brain barrier is intact in these regions. So I unfortunately haven't seen much more of this being done, and I'm not entirely sure what the status is of using this more regularly, but I think this is kind of where the really interesting things lie. And it would be good to see again how patients do post-treatment with these measures. So thankfully in animals, we can do a lot more than just giving the contrast agent IV. So I think the bottommost image will show you just the way that it was done in the human study in the previous slide. You can just give these ultra small particles of iron oxide IV, and then they're taken up by phagocytic cells, some of which end up, the macrophages end up in the CNS, and you can look at those. The other way, though, is to actually label certain cell types that you're interested in with these iron contrast agents. So you can take whatever cell you're interested in, and most often this has been done in the setting of labeling like MBP or PLP T cells, and then creating your animal model of MS, typically in this case has been EAE. So the labeled cells are injected, and then their imaging has been done, and then you can see where these T cells essentially end up in the CNS. And so this is a study that's old, but very well done, where they had PLP T cells labeled with an iron oxide contrast agent. And you can see in the spinal cord here that they've actually done in vivo imaging, some very nice ex vivo imaging. And then you can see that there's quite a bit of inflammation and demyelination in this area. And then aside from using gadolinium, there are also other agents similar to gadolinium, one of which is called gadofluorine M, which is more sensitive than gadolinium. And that's been used in animal studies. So this is an example of that. So again, in like a rodent model of EAE, where the images on the right are, the images on the bottom are your T2 weighted images. And then you can see that there's areas that are hyper intense that are not identified on the T2 scan. Again, these contrast agents are all only being used in the context of research, mostly only in animal models. But I think particularly for people who are doing these really neat immunology experiments where you're wanting to have an in vivo correlate with what you're going to do with your histology, I think this is a really interesting way to go. And I think the capacity is there to do that. And I would love to see more of this being done, particularly to look at, you know, like if you're trying an agent in an animal model of MS or something, to label the cells that you're going to put in anyways into the animal and see if you have an MRI correlate with whatever histology you're going to do. So that's just my 2 cents as an imaging person, but I think this is kind of the most interesting area for looking at inflammation at this point in time. It remains to be seen what they're going to approve for use in humans down the road, though. So I'm going to spend the least time on demyelination. There are lots of methods, and it is very complicated. And I think if you are somebody who does study myelin in MS with MR, you will be very well acquainted with these. So I think for the sake of 1, time, and 2, I think complexity, I'm not going to go into this too much, but there are many methods that exist. So there's magnetization transfer ratio. Now there's quantitative magnetization transfer. There's myelin water fraction, which was started by our colleagues at UBC. That is really interesting and makes very beautiful pictures. Diffusion tensor imaging, and then even this concept of a myelin G ratio that can be looked at in vivo with MR, the physics of which I will be honest and say are beyond me. And more and more and more continues to be developed at a rate that is really, really fantastic, but very complicated. So at this point, because some of the treatments that are being tried in patients now are focused on repair and remyelination, I think from an in vivo standpoint, we need imaging methods that can detect demyelination and remyelination and have a very clear difference between those for medications aimed at repair. And the reason this is important is because the T2 lesions that you see, so if somebody has a demyelinating event and they develop a T2 lesion, that T2 lesion, because there's been some damage there, even if they remyelinate, it may still look the same on T2. It may get a bit smaller, but it may not change in appearance at all. And so the methods that we use right now can't help us figure out if repair has taken place, and so hence these methods exist. So I'll just show kind of what myelin water fraction can look like. So to come back, actually, so myelin water fraction is a multi-component T2 sequence, and what it does is the water between the myelin lipid bilayers has a different T2 value. It's very short compared to the T2 values in other types of water, and so that's exploited in order to create a certain type of contrast. And so what they've done, at least from these studies in UBC, is looked at myelin water fraction and compared, basically imaged and compared with histology with Luxol Fast Blue for myelin, and they find excellent correlations between their myelin water fraction values and histology for demyelination. And they've actually done this in spinal cord as well. So they have their myelin water image, and they have cross-sectional pathology where they can basically delineate the same things. And so all these myelin methods, I think, are, I don't think there's one that has truly stood out as being the one that would be used down the road. And so people are trying even various combinations of these. And if you want more information on that, just let me know at the end and we can talk about that. And I'm going to stick with what I know best. So diffusion tensor imaging, I did some of during my time in Calgary. And what that does is it basically looks at Brownian motion. And so if you have free water with no boundaries, it can essentially go everywhere. And if you think of an axon in a myelin sheath, you have very like set pathways for water to flow in. And so DTI just exploits that and looks at if you have anisotropic restricted diffusion versus isotropic. So the notion being that if you have a demyelinating event, it'll become more isotropic. And so your values that you get with diffusion tensor imaging, of which there are many, will be abnormal versus an area that has myelin. And then subsequent to that, if you have a demyelinating event with remyelination, you would expect the diffusion to become more anisotropic. That's essentially the principle. So when we had done this in the lysolecithin model, where you basically inject a lipid detergent into the dorsal column with tractography, so basically the pretty pictures that you see when people talk about brain MRI, you can see that that is gone. And then in kind of a longitudinal section, you can also see with tractography that you get with DTI that area is demyelinated. So I'm going to spend the most time actually on studying neurodegeneration in MS with MRI, because I think this is one that's really taken off, and I think even clinically is kind of coming more to the forefront as an outcome measure. So in MS, you have neurodegeneration of both white matter and gray matter, and it can be measured in a variety of ways. So one is brain parenchymal fraction, where you take the ratio of the brain to the entire intracranial volume. Ventricular enlargement measured with the third ventricle width. Deep gray matter nuclei atrophy, and then for the spine, cervical spinal cord cross-sectional area. Now the difficulty with this is generally better correlated with clinical disability than T2 lesions. But if you can imagine, it would be very difficult to standardize this across centers and over time, especially as, some people are still using 1.5 Tesla, some are using 3 Tesla, some studies are using 7 Tesla. And so I think the variety also, even in the acquisitions and the way that the atrophy is measured, do you have an automatic segmentation process or are you doing it manually? Those sorts of things, I think it's very hard to standardize across centers, but I think it's a very important area. So just as an example, so these are serial T1 weighted scans in an MS patient over 6 years. And so the leftmost image, as compared to, you even take the rightmost image, you can see that the lateral ventricles are very enlarged in D versus A, and that you can see the sulcine gyri much more from A to D, and basically just a visualization of what the atrophy looks like over time. So there has been some discussion about what atrophy looks like in a normal brain versus an MS brain. So in normal aging, your brain loss is kind of at 0.05% at 20 to 30 years, up to about 0.3% at 60 to 70 years of age. MS brains tend to have atrophy at a higher rate than that. And so the proposed cutoff has been 0.4% per year. And you can see, at least in the image here, that if you look at the baseline, so that top kind of panel A, you look at the baseline image compared to the 3-year image, the number of white matter hyperintensities has not gone up substantially. There is a bit more at 4 years. But then if you look at BPF or brain parenchymal fraction in panel B from baseline up to 3 years. Again, it's not too bad, but then once you look between year 3 and year 4, right, they've lost 2.5%, and then their T2 lesion load from year 3 to year 4 has also gone up substantially. And so I think it's a very important area for us to kind of spend more time on. And then spinal cord atrophy, again, Dr. Chiwano has done a lot of work in this area as well, but what they found, even with a meta-analysis that was, I think, from 2018, looking at a bunch of studies, reduced cervical cord area can be related to increased disability, and that's independent of brain atrophy. So what they found is actually cord atrophy is more than brain atrophy, and as expected, you're going to have more of this in progressive MS rather than relapsing remitting MS. And the thing that I found the most interesting was that having cervical cord atrophy is related to disability progression, and that's independent of lesions seen in the cord itself. So I think this is an area that's also growing. Again, it's difficult to standardize across sites and to have sites that can do this really well with high enough signal intensity and ability to measure. So I think this is kind of one of the holdups, but I think this is also a very critical kind of area. And to the point where MAGNIMS is the MRI and MS group, where they've now created these recommendations for measuring brain and cord atrophy in MS. So now this is kind of moving into the clinical realm rather than sticking with primarily being research, but they kind of comment on the same things, right? Is that clinical cord loss is associated with disability, and that gray matter changes are more important than white matter, essentially atrophy, and that some of these deep gray matter nuclei have quite a bit of atrophy. And depending on the study you read, some have more relationship with disability than others, but that these can be measured and that this is recommended now. And that's just for kind of learning about disease severity. And then for monitoring the response to disease modifying treatment, the recommendation is to look at whole brain atrophy over 12 months as a secondary endpoint in clinical trials. And then to continue to basically incorporate measuring of gray matter volume in clinical trials. The difficulty is this point number 3 with the pseudoatrophy. So if you have an ongoing presence of inflammation, if you give disease-modifying therapy, you can develop what's called pseudoatrophy, because as the inflammation goes down, the edema also goes down, and so it looks like you may have brain shrinking. And so we do actually do this right now, not for the presence of pseudoatrophy, but we typically do a baseline MRI 6 months after starting a disease-modifying therapy anyway, but you would essentially have to account for that if you are going to try to use atrophy as a way to see how there is a response to disease-modifying therapy, again, which could be subclinical. And then number 5 actually mentions this use of spinal cord atrophy. Again, I think these are really relevant and very important, and I think we're going to find a lot more data as this goes on, but I think the difficulty is in making this standardized. So I'll go on to the central vein sign. So MS lesions have been seen to be perivenular from the time that pathology was coming up. Okay, I'm going to answer your question just at the end here. So perivenular lesions have been noted with pathology studies from the time that MS was being defined. And with that now, with imaging, we can use these susceptibility-based MRI methods to look at the presence of a vein in the middle of a lesion, primarily because we can exploit essentially deoxyhemoglobin affects the magnetic susceptibility in a way that it can just look quite dark. And we have good methods to be able to exploit this quality. And so we are able to look at the presence of a vein in the center of a lesion much better now than we could before. And so this has been proposed, one as a clinically relevant measure in MS, and then the other is to be able to differentiate it from mimics of MS, which can be a bit difficult at times. And so I think this could be quite important. And the definition is like, what in the world is a central vein? So the proposed criteria, at least, is that it's a thin hypointensive line or a small dot, that you can see it in at least 2 planes, and that it should run partly or entirely through the lesion. And then they have these exclusion criteria as well. So I'll just show you what an example is of what this kind of looks like. So this study had looked at the central vein sign in MS versus these inflammatory vasculopathies, which includes things like Behçet's disease and lupus and CNS vasculitis and a number of others. And so hopefully this projects well, but on the leftmost side, you can see an MS lesion. And in this axial plane, you can see a hypointense line just running through the lesion. And then in the sagittal, you can see a dot. And then in the coronal, you can again see a line going through that. Now, if you contrast that with other inflammatory conditions, which we definitely do consider on our differential diagnosis when patients present, depending on what they come in with, something like Sjogren's disease can come up. And so if you look at a white matter lesion there, you don't see any signs of a hypointense dot or a line. And then if we look at antiphospholipid syndrome, again, there is a white matter lesion and you don't see that dot or that line. And then lupus is the other one that comes up here. So I think the one condition where the vasculopathy where there were the most instances of a central vein sign, still much, much less frequent than MS, was Behçet's disease. And that's like a vasculitis of the medium-sized vessels. And so if they basically look at the proportion in MS that have perivenular lesions versus all of these other inflammatory vasculopathies combined, you can see that there's a very clear separation here. And when they apply this threshold of 50% of the lesions being perivenular, central vein sign could discriminate MS from these inflammatory vasculopathies with literally a diagnostic accuracy of 100%. So I do think this is quite interesting. And I do wonder if this will end up coming up. Again, the questions are, how does one automate this? Is it going to be consistent between sites? And I think that part's quite unclear at this point in time, but this has gained a lot of traction as well. And so I think the last kind of area I'll spend very short amount of time on is visualizing iron deposition, mainly because this is my favorite, in deep gray matter structures and to classify lesions. So some really nice work has come out of Dr. Willman's lab, obviously, at the U of A, looking at these susceptibility MRI measures that can look at iron very well and doing really nice pathology, looking at iron to correlate and see that this is quite accurate when it comes to measuring iron deposition in vivo. There are a number of measures that can be used within the susceptibility MRI world, and so if you have questions, we can talk about that. But essentially, there's susceptibility weighted imaging, there's quantitative susceptibility mapping, there's relaxometry, and the list will, I'm sure, continue to go on. But given the propensity for iron deposition to take place in these deep gray matter structures in MS and the relationship that seems to have with clinical disability, this is a nice non-invasive measure that can be used in patients and to look at progression over time, kind of along the lines of, I would say, atrophy as well. The only thing is to differentiate, is there atrophy, these deep gray matter structures, with iron deposition because things are more concentrated, or is that separate? And I think that's work that's obviously currently ongoing. And then the other use is for these iron sensitive MRI methods to look at what the lesions actually look like. So this notion of a slowly expanding lesion where the ongoing growth has surrounding it a rim of microglia and macrophages that are taking up iron, and to be able to see that. So all these areas that are essentially hypointense. And then with iron staining, you can see kind of the brown stain of iron and seeing that this evolves over time versus these inactive lesions where you don't see any hypointense rim and you don't see the presence of iron anymore, and to differentiate those lesions over time. And so just like a shameless plug for the work that I did with Wee and Jeff, is there are some very nice reviews on using MRI in MS patients, but there wasn't really anything on using them in animal models. And so for any of you that are doing animal model work and that want to know about the MRI studies that have been done or are doing MRI in animal models of MS, we did just publish 2 reviews a number of years ago now. I didn't see an updated one, to be honest, when I went looking yesterday. So one being on understanding the disease processes in MS. So we split it from like inflammation, demyelination, atrophy, and so on. And then using MRI methods to guide drug development in MS. And the reason that part's interesting is because obviously all these drugs that end up in MS patients have been trialed in animal models of MS. And some of these have included MRI. And so it's interesting to see what they find on the MRIs in the animal models and if that has any correlation with what's seen in patients. So I will end there and see what questions there are. Okay. Yeah, so first question for Dr. Yang, from Dr. Yang, and I agree with Dr. Wilman on this. I think it's just a sensitivity issue, absolutely. Just because the iron oxide nanoparticles are so tiny, so they can be like 10 to 50 nanometers, whereas gadolinium is also quite large. And so hence why these other agents, like I don't know how large gadofluorine M is, but if you had smaller agents to look at blood-brain barrier breakdown, I think that would be more useful. And then brain atrophy, I absolutely think is underestimating brain loss. And I think we're starting to see how profound the brain loss is now with some of the imaging. And I think even in clinically isolated syndrome, I think this is a factor. And then do I think clinics would use localized atrophy? I think that's actually a very realistic possibility. I think if we pick one structure, and thalamus, I think, as Alan is saying, is I think a great one, because I think there is quite a bit of literature on that. If we chose one structure that we know for sure has a relationship with clinical disability across multiple studies that's consistent, if we chose that, I think that would be a very reasonable outcome measure. I find brain parenchymal fraction will be tough, just for all the literature that I've seen so far. I think that would be hard to standardize. Is there any way to determine age of something appearing on MRI? So with T2, not really. I think that's kind of where these advanced MRI methods come in. Because once you have damage on T2, you have damage, and even if, like I said, even if it repairs itself, you won't see necessarily any change with that. But I think with some of these newer measures, particularly kind of the iron measures, and then some of these measures for myelin, so like magnetization, transfer, and myelin water fraction, I think the one I can comment on that I know for sure is for magnetization transfer ratio. When you look at something like the lysolecithin model, the MTR changes over the course of that lesion, and it's a lot easier in very well-defined pathologies, right? So MTR, you'll have peak demyelination at kind of whatever, 7 to 14 days, and then you'll have remyelination by around a month. And so with that, you can see changes with imaging that can tell you that this is what the trajectory of the lesion is, but otherwise, that can be a bit difficult. Okay. There's a question about novel image enhancers being experimented aside from iron oxide. There absolutely are. I didn't talk about PET today, but there are a lot of agents being used with PET imaging, where basically they can create any kind of tracer they want to attach to anything they want. So there's a lot more happening in that realm. I'm not sure about anything other than iron oxide. Maybe one of the other imaging people would know that better than I do. That's mostly what I've seen, though, is the use of iron oxide and then these other agents that are related to gadolinium. So there's a question about if macrophages can migrate into the CNS. So there is blood-brain barrier breakdown, but it's that we don't see it, right? So I think the issue is the gadolinium that we use clinically is quite a large molecule, and so you have to have a sizable blood-brain barrier breakdown in order for you to see it on imaging. So I think if there's a very small area of blood-brain barrier breakdown that you're not going to see with gadolinium, you, as you say, you have to have macrophages entering the CNS, but the size of that, I think, is kind of the more important thing. And so if we had smaller agents to detect blood-brain barrier breakdown, that would be better. Can I touch on the significance of perivenular lesions? So the notion is that you can have, I think, like systemic kind of macrophages entering the CNS and then through like the vein infiltrating into the white matter around that region. So you have these perivascular spaces where you'll have entry of macrophages into the CNS. With respect to the particulars of blood-brain barrier breakdown, I don't know if I can comment on that. Yes, MR spectroscopy is being used in MS research, and I did not touch on that today. So they find reduced peaks of N-acetyl aspartate corresponding with loss of neurons. It's been a bit difficult, I think, because of the like very patchy lesion distribution. So, because for MRS, like you're typically trying to pick an area of interest. And so it's been used, it's interesting, but it's hard to do consistently. I think we actually tried when I was in the lab and we weren't very successful with it at the time. So it's being used, it's interesting, but it hasn't really like made it beyond a very kind of research level at this point. Okay, there's a question about relevance of gray matter changes in spinal cord atrophy. So the studies that I've seen so far for the cervical, like the spinal cord atrophy, have mostly just looked at the cross-sectional area of the cord. Because I agree, when you think about gray matter changes, like the main thing that one would think of with that would be the fact that you have your like anterior horn cells kind of there. So they don't, I haven't seen a separation, and I'm sure that there is this. I don't know this well enough to answer this well, but I haven't seen a lot differentiating gray matter, white matter when it comes to cord atrophy. I've mostly just seen studies that are looking at the entire cross-sectional area of the cord. I'm sure there is something around that, but I don't actually know the answer to that, I'm sorry. Myelin water fraction does enable, so the question is, does it enable for looking at remyelinated areas? It does absolutely, and I think that's one of the interesting things. So there is a study that was done a number of years ago where, and I actually think this is from my own lab, but I have to remember this. This was with Jack, but I wasn't around at the time. This is before my time, where they looked at, in the lysolecithin model, because that's a nice one and a very kind of specific lesion, where they looked at magnetization transfer ratio and myelin water fraction. And there was a discordance between when the MTR improved and then when myelin water fraction demonstrated that there was remyelination. So myelin water fraction does enable for looking at remyelinated areas. And I think that's why it's been one of the methods that's been thought to be quite promising for looking at remyelination. The difficulty, again, is keeping it standardized across places. So yes, it does for white matter. Gray matter is difficult. I don't know the answer for myelin water fraction for gray matter. For even identifying cortical gray matter lesions, there are kind of more specialized MRI methods that are being used, one of which is double inversion recovery, which I didn't talk about today. I don't know if they can look at remyelination in gray matter with myelin water fraction, but to answer the first question, you absolutely can for white matter. Excellent. Thank you. Are there any other questions that I have not addressed? I apologize for the ones I don't know. There's some really beautiful reviews though, that may be able to address some of these.
Nabeela, this
Yeah.
morning I was thinking, and I actually dictated this to send later to Deepak. Deepak has this very nice data set where after he knocks out MPRIN on macrophages,
Yeah.
conditionally, mice don't develop EAE. So I was thinking that because he has some mice available, that we should perhaps do some MRI to look at macrophage infiltration into the brain. So
Yeah.
I was thinking of brain imaging rather than spinal cord imaging,
Yes.
and thinking of either GET or iron oxide imaging. What do you think?
I would do iron oxide for sure, I think, in this setting, just because you're looking particularly, as you're saying, for MPRIN to look at like the perivascular spaces and infiltration of macrophages into the CNS. I think iron oxide would be best. The difficulty with the animal model work, so I know I talk about gadolinium a lot, but when Jeff and I have talked about this for years, gadolinium is really poor in the animal model world for MS, so that's why we don't use it very much. So I think the higher yield would be to use those ultra small particles of iron oxide and just give them intravenously and see what ends up in the CNS.
Deepak. Is
Hey,
Deepak
we,
there?
I
Yeah.
just have I have a little one next to me singing rhymes.
Nice.
Okay, good.
Barely was audible. We'll discuss with you later, maybe. Sorry
Yeah.
about that.
No, I think that would be interesting.
Yeah, I think if that's what you're
totally.
expecting is the outcome, I think that would be the way to go. Yeah.
Yeah.
Very
yeah.
good.
Excellent. Thank you, everyone, for the very good questions, some of which I could not answer, but I think this is at least raising some lines of inquiry, which is fantastic.
Yeah. Well done, Nabeela. Really
Thank you
good.
very much. Thanks for having me.
Yeah, it was great to have you. And thank you, everyone. We'll see you next Thursday.
Sounds great.
Thank you, Neetu.